Veterinary Eye Talk, let's go!
Hello, everyone. Thank you for joining. We're here for another week of Veterinary Eye Talk. Myself, Dr. Ben Reynolds, here with my co-host, Dr. Paul McCarthy. How you doing, mate?
Yeah, not too bad, mate. Yourself? How's your week been?
Pretty good. Same old stuff. Another week in Las Vegas. About to move house, so lots of packing and stuff. But otherwise, same old stuff. How about you?
Yeah, not too bad. It's actually so it's public holiday here in Australia. It's Australia Day. I played some golf with a future podcast guest, Jeff Smith. So Smithy has confirmed that provided we can teach him how to set up a microphone and record, which I think, he's acknowledged that may be a bit of a challenge, but we'll get him there. He's
That's
happy to
huge.
come on.
That's huge. That's a huge get for our podcast, our very first guest. So that's a gigantic milestone. What a privilege. That's
Absolutely.
awesome.
And no better than Jeff Smith. So for those who don't know, Jeff's probably he's one of the original ophthalmologists in Australia, trained at Cornell. We'll do a better intro for him when he comes.
I think he was, I could be wrong, but I think he was number 2. I think it was Rowan Blogg in Melbourne, and then he came to Sydney. But yeah, incredible. Yeah, that's a huge get. That's a huge get.
His only caveat was, we had 2 things. One, we have to set him up on a microphone and everything, which is easy. And then 2, he said under no circumstances would he talk about glaucoma. So, give a topic.
Fair enough. And most importantly, though, who won? Who got the lowest score in your golf game today?
Look, Jeff's a much better golfer than I am. I'd love to lie and say that I had him at any point, but no, we actually just played a social game, so it was good. Very relaxing, nice weather, beautiful course that he's a member at, so it was good. I didn't embarrass myself too much, which was nice. But if you guys will all see Jeff. For those who don't know him, he's a great laugh, and he's a lot of fun. And then before that, I was actually down in Oberon, down mid. It's inland for a country wedding over the weekend, which was unreal. So it's been busy, but it's been fun.
Good for the soul, my friend. Just touching on Australia Day, there was a local event on in Las Vegas for a bunch of Australians to go to. For some reason, there's a pretty large proportion of Melbourneites in Las Vegas, and as a former Sydney sider and New South Wales country boy for most of my life, the sport of AFL just has not found me. I haven't found it. So anyway, there was an advertisement though for all these Melbourneites to kick an AFL ball around and whatever, and I was like, I'm going to be useless, so I'll go down. So anyway, met some Aussie lads and had a good time anyway. But yeah, didn't do myself any favors showing off. Any potential athletic ability I had was not translated kicking the Sharon around. Let me tell you.
Yeah. Oh, look, I'm sorry to hear that. Look, it's good you got some Australians over there. I'm sorry to hear that they're from Melbourne.
Yeah, I know.
Anywhere would have been better. In fact, I know David Maggs is from Melbourne.
He's the exception to the rule. He likes rugby, and I talked to him about rugby league, and he at least entertains the conversation. So he doesn't watch AFL, so we like Maggs. He's the exception to the rule.
He's the exception. Yeah. All right, mate, what are we talking about this week?
Absolutely. So yes, let's talk some eyeballs. So this week we're going to touch on a topic that we're very, very lucky. Paul is a bit of a pundit of knowledge on, a wealth of information on all topics eyeballs, but especially this one. We're going to talk about a very specific retinal disease that we see often in practice, and it's a great imitator. When animals present with this, often the history we read, the referring vet is suspicious of many, many diseases that can cause sudden blindness. We are, of course, talking about Sards. Paul, do you want to run us through a bit of an intro to what is Sards and what we typically see?
Yeah, no, thanks, Ben. It's very kind of you to say that about me, but I don't think anyone's a wealth of knowledge with SARS because we haven't really, there's not really an established, what is known about it is quite little. I happen to be a bit interested in it from I guess, a research point of view, which was a mistake. But because it's one of those areas where there's a lot of very strong opinions, I guess, and so you sort of open yourself up when you're a resident presenting on that topic. It could be quite daunting. But no, look, I know a little bit. I guess as much as probably anyone else in the college would know, to be fair. And then I think there are a few people out there doing some really cool research in the area, and I've been fortunate enough to be able to at least liaise with them on some projects, and I've been really fortunate in that regard. So I've just been lucky to sort of be the resident who's, I guess, stupid enough to take on a project on the topic, and then as a result, have been very fortunate to have a lot of diplomats who know a lot more than me come in to save me when I was sort of drowning in the information. But look, Sards, just for everyone out there who doesn't know, and I'm sure if you're an ophthalmologist listening to this, I'm sure you know everything I'm about to say. If you're a general practitioner listening to this, then you've probably heard of Sards. I guess the way, and this is the thing, you can trigger people in so many ways talking about this, because if I call it a retinopathy, I feel like that might upset people because there are systemic signs, but we do know that it does affect the retina. As Ben has said, and as the name suggests, it is a sudden onset of blindness, but the definition of sudden, I guess, can be somewhat loose in this case, because we have seen some papers, and I've certainly seen some cases clinically where the vision decline is not as sudden as perhaps it was originally thought. And animals or dogs, I should say, because it's a canine disease, are losing vision over a period of several weeks to months, as opposed to in one sudden hit. It is, should we say, exclusively bilateral. I mean, I've never seen a unilateral case. I don't believe one's been reported, but it can be asymmetric.
Yeah, in the asymmetric paper, there's one dog that retained vision in one eye long term, but it was on the ERG, it was impacted and lower. So you're right, like it looks like it's always bilateral, but yeah, asymmetric. And they're really rare. Like obviously that's a really rare.
I've seen a case which has been asymmetric. I've never seen a case not go blind in both eyes, and we'll talk about that.
I just realized we actually haven't introduced we haven't defined the acronym of what the 5 letters stand for. We should do that.
Okay, so, and this is funny because when I first, for the longest run, I was calling this sudden acute. I don't know, I can't remember why, but I just could not get in my head that it's sudden acquired retinal degeneration syndrome. But for the longest time, and when I went to present on a paper that I'd done at an ACVO in Boston, the whole time I was like, just whatever you do, Paul, do not call this sudden acute. So anyway, luckily I just, you can call it Sards, and everyone in the ophthalmology community will know what you're talking about. I guess, Ben, do you want to fill us in on a bit more information about I guess the defining features of Sards, and then we can sort of bounce off each other?
Yeah, sure, absolutely. So yeah, Sards, sudden acquired retinal degeneration syndrome, as Paul mentioned. So the features, like the presenting complaint from the owner, is normally a sudden blindness, as Paul touched on. Sometimes sudden means one day, sometimes sudden means over a period of a month or two. Essentially, often dogs come in, and the most classic presentation is, in the last day or two, suddenly the patient's blind, they've got really broadly dilated pupils. There's often a systemic history attached that involves either polyphagia, so eating a lot more, weight gain, and that weight gain can precede by a handful of days up to a couple of months even beforehand owners report. They're often PUPD, so drinking lots of water, urinating a lot as well. Often a lot of these signs correlate with other endocrinopathies. So often when these patients come to our door, they've been worked up by their very vigilant referring veterinarian, who has investigated things like Cushing's disease, and often on blood work, we find that hepatic enzyme elevation is present. And so often these dogs are either getting supplemented with liver supplements, or they're getting worked up for atypical Cushing's. And then as a side, then a few days or weeks into that symptomology of being PUPD, polyphagic, those blood work changes, suddenly the vision disappears and they end up on our door. So that's sort of what we see. We know if we were to look at the retinas of the affected animals, basically it's a really sudden autolysis of the photoreceptors. So both on histology in the good old days, but these days with advanced imaging techniques like optical coherence tomography, which is like a in vitro cross-section of any tissue, but you can use it for the retina. Essentially, we can see that the retinal architecture, the most heavily affected zone is the photoreceptors. So I'll let Paul, he's going to be the best person to explain what may, or possibly more accurately, what we know, what may not lead to all of this. Because we know there's, some patient risk factors. But yeah, I'll let Paul, if you want to lead on to, why we think where all of this knowledge has taken us into what might be causing this.
And this is Ben's throwing an absolute hospital pass there, because no matter what I say here, someone will disagree with me. And I suppose it's look, it's good. I think there is a lot of I know there are a lot of varying opinions about what may or may not cause SARS. And so I'd preface this by saying, look, you are probably, what I'm sharing is my opinion based off what I've read and what I've seen. But I definitely, far from know everything, particularly on this topic. And so there'll be some varying opinions out there, and some, some stronger than others. And so, I think all opinions are worthwhile entertaining, and particularly in a situation like this where truly we don't have a definitive consensus on the topic. I think the more ideas and the more sort of thinking we can have out there, the better. So with that little disclaimer, I guess we can start with, the typical signalment. Now, when I started and when Ben started, I'm sure he was told the same, that it was sort of small, white, fluffy, overweight female dogs, middle age was sort of, the poster child. I think my attitude towards that has definitely changed over the years, and there's a few papers that have definitely shifted the thinking about what breeds are and aren't predisposed. One of the challenges with predisposition and studies around that, particularly in an ophthalmology setting like ours, is that there's an inherent, bias to what breeds present to your practice. So I think there was a lot of, reports out there, whether it be papers or discussions at clinics about, I see this breed and this breed's definitely predisposed to SARDs. But there aren't many studies that I can think of. There's one study, I think, and I'm happy to be corrected on this, but by Orton, that came out of the group at UC Davis, that actually compared their SARS population to a database they have, which is basically a vet hospital database of what the most common breeds are over there. So I've always sort of used that as my reference. And I believe, Ben, do you have the paper handy? Because it's been a while since I've read it, but from memory, I believe they found mixed breeds were predisposed. The Dachshund popped up, and I believe the miniature Schnauzer.
He's good. He's good. Yeah. As well as the Pug and the Brittany.
And the Brittany.
There you go. Now, Yeah, and the Labrador was significantly underrepresented. There you go, compared to the reference population. Yeah, so yeah, to your point, Paul, yeah, absolutely. We know there are some breeds that seem to pop up more often than others. Paul's being very humble in neglecting to mention his own research that touched on the weight of animals. So I guess I was trying to create some breadcrumbs for him by mentioning that often there's some weight gain noted beforehand, and historically it was thought that possibly the weight gain was a consequence of Sards. But Paul, I think you're going to have some interesting insight for some recent finding, possibly.
Yeah, so no, thanks, Ben. I forgot about it. That's me suppressing the
So humility or forgetfulness, one or the other.
Or both. So, and this was a paper that I was really fortunate to have the help with, not just the team at iClinic, but the team overseas at UC Davis, particularly Professor Sarah Thomas. He helped me big time with this, and we set out to look at whether or not anti-parasite use would be potentially implicated as an agent that could cause, SARS. And the justification for that was a couple of things. One, a lot of the big tick paralysis or anti-parasite drugs came out in the 70s, which was, particularly the macrocytic lactones. And that was around the same time that SARS sort of started to pop up.
Which, sorry to cut you off, but it's just the perfect prelude as to, we're talking about getting Jeff on earlier. Like our colleague, or for me, former colleague, as you know, I used to be at iClinic for Animals in Sydney, Australia, now in Las Vegas. But yeah, he started his career and SARS did not exist. And then just out of nowhere, these cases popped up all over the world, like, South Africa, Australia, England, US, like wild. Like, can you imagine that? That's crazy. So anyway, maybe that'll be a great topic to talk to him about. Anyway,
yeah, we should. Yeah. Maybe with Jeff, we just do a bit of a history, like a walk back. And honestly, with Jeff, I think we just let him talk. He's so good.
Yeah. We will absolutely be in the corner and just say the floor's yours, mate. Like, yeah, he's a wealth of knowledge. So much to learn from him. I'm so grateful to have been trained by him. Absolute legend of a man. But anyway, enough about Jeff. We'll get back onto Sards. But yeah, I'm pumped that we're going to have him on. That's awesome.
Yeah. So basically, when I was starting my before I started my residency, when I was still a student, I was madly looking at the different timelines of when the drugs were coming out and sort of doing a deep dive to see if there was any sort of correlation. And, I know correlation doesn't mean causation, but these drugs had sort of been blamed by people before. I think there might be people out there who still believe that the drugs are involved. In fact, I know there are. And so we sort of set out, and Ben was involved in this as well, to look to see if there was any association. In the process of doing that, we also wanted to come up with a hypothesis for why dogs seem to be overweight, or why overweight dogs seem to be predisposed, which at the time I believe was, a somewhat anecdotal thought, but definitely was something we saw clinically. The overweight dog, the Cushingoid-looking dog, would be the ones that would often be predisposed, or not predisposed, but we thought, that they're the ones that we thought were predisposed. What we ended up finding was we didn't find any association between parasiticide use and SARS, but in the study we did find that actually being overweight was a significant risk factor for the development of SARS, and then being obese was an even bigger risk factor for the development of SARS. And that was probably the most powerful finding in the study from a statistical point of view, and also from a I guess just an information standpoint, because
it's huge. I think that's huge. It completely changes the dynamic of, we used to think obesity was a consequence of the disease, but just like so many other diseases in human medicine, canine medicine as well, being obese is a risk factor of this retinal disease.
Which is, I don't know why, so don't ask me. I mean, we sort of, I don't think we even really got that far. I think we were just sort of it was enough to find that finding, and I hope someone else can take that a bit further. But yeah, so that's, I guess, the signalment factors. Sex, so in terms of which sex it is, I think it depends on which paper you read as to whether or not one sex would be predisposed over the other. Typically, though, I think you hear more people say females are predisposed. It's certainly been what I've been told. I'm not so sure that I really necessarily subscribe to that personally. I think I guess not personally, I mean, from a clinical standpoint, I wouldn't be honing in on those factors in trying to find a diagnosis. I do think, depending on where you are, breed can be a good indicator. Looking at the cases, when I've looked at the cases in Sydney, and now I will preface this by saying we do not have a good control population for looking at whether a breed is truly overrepresented compared to what's out there in Sydney. But we do see a lot of miniature schnauzers coming into our clinic with Sards. Probably would be the most commonly diagnosed breed. Now, is that just that there's so many more miniature schnauzers in Sydney? I don't know. That's why we didn't go down that path in the paper that we wrote. And we definitely see a lot more dash hounds than other breeds as well. They're probably the top two. How about in Vegas? Is it similar, you feel, or?
Yeah, pretty similar. You can go weeks without diagnosing a single case, and then I had a day last week where I diagnosed 2 on the same day. One was an Alaskan Kleekai, which I think was my first ever Sards diagnosis in a Kleekai, and probably my 3rd ever Kleekai I've ever seen.
Yeah.
And then another was in a Shih Tzu. So both, I mean, and this is not, N equals 2, so don't overinterpret, but yeah, both females, both within the 5 to 8 year age range, both overweight. So I guess if not every Sards case is a female, and, as you alluded to, Paul, some studies indicate there's, some even have males as more represented than females. It's just historically it was thought to be overrepresented in females, but I certainly echo your sentiment as well. It's hard to know, do we diagnose it more in these breeds because they're commonly owned breeds? The Davis paper you alluded to, the Orton paper, is really powerful in that essence, in that, there was a really nice control population. Why Labradors appeared to be underrepresented, super interesting, I wonder. But yeah, it sort of just more sheds light on what we don't know about the disease and what we do, which I think kind of sums up the pathogenesis of Sards. There's other papers that show there's, some genetics that particularly like a risk factor in the dachshund, for example, but there were really weak associations, and there were certainly dachshunds even within that same breed who got Sards and didn't have those genes. Just if you have those genes, you seem more likely to get it. So how much you can really interpret that, difficult to know. So I don't know. Where's definitely information is mounting, and I think we'll get closer to an answer. And I guess just to do full justice of the whole breadth of what's out there, there's other studies that indicate maybe this is an inflammatory or autoimmune process as well, but certainly all the information isn't put together with that either. So there's a couple of conflicting theories, none of which by any stretch is definitive. So I know when I was at Eye Clinic for Animals in Sydney, we were definitely of the camp, as most ophthalmology clinics are, that this is not a treatable disease, and treatment wasn't something that we certainly attempted. Since I've left, has that changed at all? Have you guys been attempting treatment, or do you want to give the listeners a bit of a background on what treatments are out there? And I feel like I'm throwing you hospital pass after hospital pass. Here I am. Yeah.
No, great question. I guess, look, there's a lot of, and you can, if you do reach out and read yourself, you'll see there are different treatments out there. There are people who advocate for heavy immunosuppressive use. There are immunoglobulin therapies that can be done. I've got to say, I've got to be careful, I guess, because I don't have any first-hand experience with anything but cases that I've seen from other people that I've practiced with, where they put them on immunoglobulin suppressive drugs because they've decided that they've reached a diagnosis of immune-mediated retinitis as opposed to Sards. Now, in those cases, I've seen them get put on very heavy immunosuppressive doses. So I'm talking, big doses of pred. And when I've seen them for the follow-ups, I have never seen an improvement in vision. Ultimately, I also end up invariably diagnosing them with Sards when I do an ERG and the electroretinogram, which for those who don't know is the electrical test we use for the retina. And the criteria, we should say the diagnostic criteria for Sards is a severely attenuated electroretinogram or a flat electroretinogram. So either a very low waveform or a flat one. So you can still have a Sards diagnosis and have a very attenuated ERG. In my experience, eventually it'll go completely flat. It's just about where you catch it. But I don't think it just switches off overnight like like it's sort of described to.
And to your point as well, we're on that. We should should elaborate on that a little bit. So classically, when you examine the retina of these dogs with Sards, they appear normal. Of course, later in the disease, we start to see indications of retinal degeneration, but in the acute setting, when they present, classically, you got this acutely blind dog, and you examine them, and their eyes are completely normal, which is the really confusing part of this disease. But as Paul alluded to, the electroretinogram indicates there's no retinal function. So, that tells us that that's where the vision loss is. The benefit of that, while we can't just diagnose Sards off, signalment and sudden blindness and clinical signs, optic nerve disease or central blindness, if there's a meningoencephalitis where the visual cortex is the predominantly affected area, the eyes would also look normal in an acutely blind animal. So, that's the benefit of the electroretinogram. So anyway, so I just thought it was worth touching on that while we got there.
Absolutely. And I think just, I guess, leading on from that, for those out there, if you have a dog presenting with sudden vision loss and you look in the eye and you don't see any obvious cause of vision impairment, so you don't see cataracts, you don't see significant corneal disease, the retina's not detached, and everything looks very normal to you, I guess that's your big two differentials, right? Is it central blindness or is it a retinal blindness? And if it's a retinal blindness, Sards is sort of the one that if you're not seeing any changes to the retina that you should be suspicious of. Those other points that Ben mentioned previously about polydipsia, polyuria, weight gain, and the history can be helpful as well in terms of guiding you there. But ultimately, to get the diagnosis, you do need to do an electroretinogram, which often means sending the case to an ophthalmologist. Now, excuse me, sorry, about to sneeze. Excuse me, sorry. Now, I think the selling point for the ERG, at least at our practice, is you can get a diagnosis fairly quickly with minimal invasiveness.
Yeah.
And it's a lot easier.
Rarely need to sedate them or do a general anesthetic. That's really rare.
Yeah. Whereas, so I usually start with that and I say to clients, look, maybe we might need to go to an MRI if this comes up normal. But an MRI is obviously a lot more invasive. I'd imagine at most places it'd be a lot more expensive. And yeah, that's the starting point.
Yeah.
So we've covered that. Now, I guess circling back, we've done this in an unusual way, which I feel like is my fault.
No, not at all. It is what it is. This is organic, baby. This is the medium. This is podcasting, warts and all. So anyway, we'll get better at it as we go on. But anyway, it's sort of it's free flowing. We're new age podcasters.
Exactly. If you can follow. So this is the problem when Ben gives me a topic to sort of try and lead on. I think my brain is, my ADHD brain's going all over the shop. So
yeah, blame me. I was meant to host, so blame me. It's all good. We were touching on treatment, and I've just pulled up a paper by Hopper et al. 2021 in veterinary ophthalmology. So looking at all sorts of neuroprotective therapies for different diseases. Because I was actually a little bit insecure when I was like, I don't think we didn't treat it. I certainly still don't treat it in Las Vegas, but my gut feeling was the majority of ophthalmologists do not treat it. And I'm buoyed by the results here that say only 5% of clinicians, when interviewed in the last 5 years, had attempted treatment of Sards. So we're not alone in that. We're definitely in the majority of clinicians who don't attempt treatment on Sards. You were mentioning, Paul, options such as intravitreal immunoglobulin therapy and immunosuppression and things. Is that something, you've never attempted that, or have you seen patients with that attempted, or what's your experience?
So I've heard of another practice in Sydney that has tried it on about 5 or 6 dogs, and they didn't get favorable outcomes. And I think, over here in Australia, it's tough for us to get our hands on that stuff. And the heavy doses of immunosuppressives and the immunoglobulin therapy don't come without risks associated with that. You're doing big doses. And so I think if you are going to entertain that, you really need to be transparent with the owners about what the possible risks are, is all I would say. There is a paper that came out of the Mawat lab. I'm not 100% sure who the author was from memory, but they looked at the outcomes of using, I believe it was mycophenolate.
I just got it. I won't claim to be a paper savant. I've got a database in front of me as Paul's talking, but that is by Whitney Young et al. 2018 veterinary ophthalmology. There you go.
And my recollection is they didn't see any improvement with those doses, or with the drugs that they use. So I think the evidence out there is spotchy, at the moment.
Sparse, absent.
Yeah. And so for that reason, I don't. Now, I will say I've had, and we'll talk about this later, I have had the odd case of Sards that has transiently recovered vision and then subsequently lost it. Now, we can talk a bit more about that. It's very uncommon.
Yeah.
And I don't know what to make of it. And then I have even had one case that was diagnosed with Sards at our practice, and then subsequently, several months later, regained vision and has now got vision. Now, my suspicion...
That's awesome. I'd love to hear your thoughts. What's going on?
There's a couple of theories about this, and I think the most likely thing is the diagnosis was probably incorrect, because I can't think of anyone else who's ever seen anything like that. The dog was not given any treatment or anything to, no immunosuppressive therapy, no nothing. In saying that, we did have a flat ERG, and then several months later, vision and a proper ERG again, and the dog is still visual. I don't have any idea how it's happened, and I would say that's very much.
Is this the very first non-human saint? Is this an act of a miracle? Is this Australia's second saint? Is Fluffy from Artarmon? No, that's awesome. I mean, yeah, I got no answer for you there. Especially given that the proper diagnostics were performed, you had a flatline ERG, dog regained vision, ERG returned. That's very strange. I guess just touching on why, I guess, in my thoughts, why I guess treatments are going to be very difficult. Like, as we've alluded on, we don't really know why this disease happens. The retina is a nerve. Like, even if we knew the cause of the neuropathy, basically, or the photoreceptor destruction, very, very difficult to make a nerve not function again. So even if it was the perfect treatment to stop it in its tracks, like the horse is bolted, we've got this obliterated retina. The dogs present blind, like the damage is present, it's very, very difficult to turn that around. I wonder the cases you mentioned earlier that are rare but do happen, and I agree. Like owners certainly report, like waxing and waning vision, and then even though the menace response is a really crude assessment of vision, at initial consultation, you're convinced the dog's completely blind, and then at a reach, you're like, oh, geez, like did that dog menace at this certain quadrant or something? We know that a significant portion of dogs with SARDs, when they're assessed with opticocoherence tomography, which again is that in vitro cross-sectional analysis of the retina, we know a lot of them do have retinal detachments, like really low-lying serous detachments that the thought is maybe it's like some inflammation from, or like the damage from the RPE, and then some little bits of fluid have leaked underneath the retina. I wonder if maybe there's some intact retina that's transiently detached and then reattached for a brief period, but then the photoreceptors subsequently get destroyed from the SARDS process. I don't know. These are just thoughts, I guess. But it's a crummy disease and frustrating all the same. I guess, like, to me, the forever optimist part of my spiel to owners, which is true as well, is these dogs have normal duration of lives. If I could pick a reason for sudden bilateral blindness, the other things on the list are pretty poor diseases. Like if you've got central disease or bilateral optic neuritis, very, very rare, but things that can cause that are not good diseases. Like often at this part of the world, fungal disease. So where I currently am, valley fever is very common, or blasto in other parts of the US for dogs. If you had a tumor sitting like just on the visual cortex, or you had meningoencephalitis and the other neurologic signs were really subtle, like, these are all bad diseases. So it's also a painless disease. Other causes of blindness like glaucoma is quite painful. So anyway, like I try and fill my owners up with a sense of optimism, and that despite this being the new reality for the patient, like it's not marred with a terrible prognosis for life, which I guess is a nice take home.
Oh, I think that's so true. And when I talk to owners about this, before we do the EIG, I usually say to them, look, in some ways, the diagnosis of SARDS is the best possible outcome here once we do that EIG, because, as Ben's already said, the other options are not good. And other dogs that I've seen that have ended up not having SARDs, I can't really think of any that have gone on to have good outcomes after, when they've gone to perform the MRI or what have you. It's not good. I think we should also, just briefly talking on diagnostics, there's one other test that can be done, and I think it's really worth mentioning, and there's a great paper out there about this, and it's called chromatic PLR. And this is actually something that I think would be quite accessible at a general practice level. In terms of, I'm not sure how much they are to buy, but performing the test is very, very simple. And basically, you take this device, and it will shine two different lights at different wavelengths. One is a blue light, and the other is a red light. And it's helpful for not just diagnosing SARDs, but that's what I mostly, I think, exclusively use it for, or I shouldn't say diagnosing, because it's not definitive, and that's something really important. But effectively, when we shine the red light in the eye, because the photoreceptors have often been damaged or have been damaged first, we won't see the pupil constricting in response to that. And then we shine the blue light, which will basically, and Ben will be way better at explaining this, because I can never articulate it, but there's a second melanopsin-driven pathway that goes via our ganglion cells, which should not be damaged, at least in the early phase. And so we will see often a very really crisp response with the blue light. And when I see that in an at-risk breed with no other neurological signs, you're sort of 95% of the way there. And the only reason, you really need that definitive EIG is because, as Ben's already said, the alternatives can be so significant and potentially detrimental. So, or it could be something like a tumor or an infection in the brain, nothing good. So that's kind of why we take it that next step. But if you're in a scenario where perhaps you're in a practice where there's not an ophthalmologist nearby, you can't get an ERG, but you can rely on something like that. It's pretty good.
Yeah, I am. To your point, Paul. Yeah, I think it's a wonderful test you can do to increase your index of suspicion of Sards, but you need the ERG to confirm it. I was just Googling that actually out of interest how much they cost, because I don't know either. But yeah, for about $200 you can pick one up off Amazon, thankfully. So yeah, depending on how often you'd use it, like might be a really handy thing to have. The only funny little anecdote, I guess, you explain to owners like, look, there's this test I can quickly do. We use different wavelengths of light. They target different areas of the retina. I can actually see what part of the retina is getting stimulated more. It just helps lead me down a direction, all of which is true. It just sounds like you're about to do something really impressive. And then you pull out this little light and you shine a red light, and then you shine a blue light, and you're like, all right, Mrs. Jones, thank goodness we did that test. I don't know. It can be, it's a bit of a letdown, unfortunately. So dang. Anyway, so yeah, if you are to do it, either, I don't know, one of these days I'll probably hype the test up a little bit less, or I might have to take the patient out the back or something just to keep the mystique intact, I think. And it looks like I have lost Paul. Paul, you still there? You're frozen at the moment. Hello. Dang. Well, I think we covered treatment, we covered diagnosis, and we covered who's at risk. This might be the natural endpoint, I think. So if you're still listening, really appreciate it. It's probably actually a blessing, because Paul and I love to talk, and this is a topic we could talk about ad nauseum. So I will say farewell, and thank you for listening to another episode. Hopefully next episode we'll finish with the same amount of people we started it with. That'll be really good. All right. Thanks, everyone. Bye.